Hello, we have learned many things this semester. One of the first things we learned about was fetal circulation. And with fetal circulation, the lungs are not in use. The fetus gets the oxygen supplied to it from the mother's placenta. So with the lungs not needing to be used, there are shunts that are used to bypass the lungs and also the liver, which I did not know. There is the ductus venosus, the foramen ovale, and the ductus arteriosus. The ductus venosus helps bypass the liver, and it is found in the umbilical vein. The foramen ovale shunts blood from the right atrium to the left atrium, and the ductus arteriosus shunts blood from the pulmonary trunk to the aorta, which then sends it throughout the body, and then back into the umbilical arteries, which takes it back to the placenta, and the cycle continues. Changes that typically occur after birth are the closing of the foramen ovale with the child's first breath, the closing of the ductus venosus with muscle contractions, and the closing of the ductus arteriosus, also due to muscle contractions. If these do not become closed after birth, the foramen ovale is then known as the patent foramen ovale. But if it does close, it becomes the fossa ovalis. With the ductus arteriosus, if it does not close after birth, it becomes the patent ductus arteriosus. And with the ductus venosus, after birth, it becomes known as the ligamentum venosum, because the umbilical veins are obsolete after birth, and so this is just not needed. With the ductus arteriosus, if it does close correctly, it becomes the ligamentum arteriosum. Moving on, we have the views of the 2D imaging and InMode and Doppler. Okay, with InMode, it is a 1D image, and the way we learned it in class is that it's an ice pick image. So if you were to take an ice pick and stab it through someone's heart, the line that it follows is what is going to be shown on the 1D image. I typically really prefer doing measurements in InMode because you can see things more clearly, and probably because we've practiced these a lot. The measurements that we take in InMode are called Techholz measurements, and we do these in systole and in diastole. And typically these are done in the peristernal long axis and the short axis. I haven't seen it done in any other views. But the color Doppler is used to examine velocity and direction of blood flow, and the spectral Doppler is used to measure the velocity and direction of blood flow. And there are 3 different types of spectral Doppler. There is pulse wave Doppler, which has a sampling gate. There is continuous wave Doppler, which gives us a range. It's not specific like the pulse wave. And then we also have the non-imaging, also known as the PDOF transducer, which does not give us an image, but it does give us improved recordings to take our measurements from. So this is very helpful in determining stenosis, and it's actually required if you are grading aortic stenosis. All right, as far as the views of the 2D imaging, we have the peristernal window, which we have the long axis and the short axis. We have the apical, suprasternal, subcostal, and in the peristernal long axis, the views that we typically see are the left ventricle, the right ventricle inflow tract, and the right ventricle outflow tract. And then in the sacs, we have the apex, the papillary muscles, the mitral valve, and the base. And when we're doing an echo of this, we typically take images of all of them, and we also do like a video clip sweep through all of them. And I really like this because you can see the valves really well. As far as apical, we just learned this in lab, so I really like apical too. It can be very difficult to get really good 2-chamber images, but the views that we have are the 4-chamber, 5-chamber, 2-chamber, and the 3-chamber, which can also be known as the long axis of the apical. All right. And then we have the suprasternal, which is going to be up here by your neck. And we typically just have the long axis and short axis in that. And we're just determining if there's any issues in the aorta. And then that's where we can visualize the aortic arch. And then we have subcostal. We have the four-chamber view, the inferior vena cava, and the descending aorta. And we also have the sacs, left ventricle, and base. We have not covered subcostal very much in lab, so it's hard for me to recall these views, like from memory. Next chapter, we went over the standard protocol for a transthoracic echocardiogram, and I decided to talk about the required equipment for the transthoracic echocardiogram. As far as the transducer goes, you want a low-frequency transducer because they can see deeper into the body. And with looking at the heart, it's not superficial. So we want to be able to see the structures within the heart, and we want to be able to visualize them well. So you typically use a 2 to a 5 megahertz transducer. We also need acoustic gel to be able to have the medium for the sound waves to travel through into the body in order for us to obtain our image. We also need, of course, the exam bed, clean linens for each patient, gown for each patient. We also need our sonographer's worksheet, the ultrasound machine. We need our gloves and electrodes. Those are very important. We have to have the electrodes in order to make our diastolic and systolic measurements in the proper location. As far as the standard transthoracic echocardiogram protocol, excuse me, it goes through each of the views, and it starts in plaques and goes into sacs, into apical, subcostal, and suprasternal. And this is tricky because we've learned in lab a completely different protocol. But what we learned in the book is similar but different. So typically when you go through each one, you're going to take a 2D image, then you are going to put color on it. And when you're in the 2D image, you're typically going to take videos and still images, and if measurements are required, you'll take measurements in those. Then you do the color Doppler, check for regurg, stenosis, things like that, and then you will use the pulse wave and the continuous wave, which both are not always used on everything, so you have to remember what's used on what. And then sometimes, like only in the apical that we learned about TDI, which is a tissue Doppler. And you use this to look for declined function in the septal or lateral walls. And so this is a good thing. With the subcostal, you definitely want to determine the function of the inferior vena cava because that's very important. If there's something wrong with the inferior vena cava, it can cause a lot of issues within the rest of the heart. And then with the suprasternal, like I said before, you're typically just looking over the aortic arch and just making sure that all the arteries look good and there's no blockages, and you check the pressures. And so then moving on. In the next chapter, I decided to talk about the transesophageal exam and the sonographer's duties. And I don't have these memorized, but we're going to prepare the lab. We're going to collect supplies and equipment needed. We're going to check the probe to make sure that there's no cracks, no damage, nothing like that. We're going to ensure that it's working properly, that the TE probe is working properly. We're going to operate the machine, as in we are going to be recording and storing the images and obtaining the images for the physician. But the physician is the one that inserts the probe, and they're the ones that actually steer the probe. We are not in charge of that. We pretty much just are the photographers. We take the images. And then clean and inspect the probes and put them away after the exam. Next, we have types of stress echoes. There's the treadmill, there's the bike, and then there's the pharmacological. With the pharmacological, you're going to be getting an injection in different intervals instead of exercise. And this is usually Dopamine. And with a treadmill stress echo, you are going to take images in the parasternal long axis, the short axis, the 4-chamber, and the 2-chamber. But you're only going to take rest and in-post images. With the supine, you're going to take all 4 of those views that you used for the other one, but you're going to have a rest, a peak, an in-post, and a final image for each of those. And then for the pharmacological, images obtained are going to be all the same 4 views, but you're going to have rest, low dose, peak dose, and final. Moving on, with the cardiac cycle, we have diastole, the IVCT, the isovolumeric contraction time, systole, and the IVRT, or the isovolumeric relaxation time. So with diastole, the ventricles, they are relaxing. So they are filling at this point. And with the IVCT, all of the valves are going to be closed. So that's just, it's resting. Everything's good. And then with systole, this is the period where the ventricles are going to contract and they're going to eject that blood out into the body or into the lungs. And then the IVRT, all valves are closed again, and this is when the atrial pressure begins to rise because that blood has come back into the atria. All right, and then we have systolic function, wall segments, and coronary artery distribution. So I have this nice little diagram right here that you probably can't see very well, but in my image you'll be able to see it. It has 17 numbers on it, and they each represent a different segment of the heart. So number 17 is like if you were looking at the apex of the heart. So that's the point of the heart, and then they go up. And so when you're determining the systolic function with the wall segments, say that wall segment number 1 was not functioning properly, then you would know that there was probably an issue in the left anterior descending artery, because that is connected with that artery. There are 3 different coronary arteries. There's the left circumflex artery, the left anterior descending artery, and the right coronary artery. And these all correlate to the 17 segments. Some of them have more than one artery connected to them. And then we go into phases of diastole. There's the IVRT, which we talked about, which is where the atrial pressure rises. We have the rapid filling, which follows the mitral valve opening. And this is when the ventricles begin to fill with the blood. And then we have diastases. This is atrial and ventricular pressure equalize. So they're going to be the same pressure. And then we have that followed by atrial systole, which is where the atria contract, like I talked about. And then finally we have diastolic function, 2 diseases that when present should make a sonographer perform diastolic function measurements. The first one that I want to talk about is constrictive pericarditis. This is pretty much pericardial thickening, which in our plaques view, which is our very first view that we typically take in a protocol, this is going to show us if the walls are thick, if there's thickening. And if there is, you should know that something's not right. And so then you should be able to do further tests and determine what the issue is. The second one is ischemic wall motion. When some segments of the cardiac walls do not work properly, like they don't contract and relax like they should. So they're doing wonky things. We have a grading scale for this from 1 to 5. But when determining this, we use that scale, and it helps us to determine the severity of the ischemic tissue in the cardiac walls. I hope you enjoyed this video, and I have had a wonderful time this semester. You have a wonderful Christmas. Thank you.